Okay, so this is the cardiac or heart chapter. Get this one here. Okay. The walls of the heart. The heart, as well as blood vessels, are composed of 3 layers of tissue. We have the epicardium, which is the most outer layer, the myocardium, and the endocardium. So the epicardium is otherwise referred to as the visceral pericardium. We have a connective tissue layer to the outside of the heart. Remember when we looked at serous membranes, we said that there was a visceral pericardium and a parietal pericardium, and the visceral pericardium is also considered to be the most outer layer of the heart. So that is composed of connective tissue, and it helps to protect it. It serves to anchor blood vessels and nerves, smaller blood vessels and nerves to the heart as well. Then we have the myocardium, which is the middle layer. That is composed of cardiac muscle tissue. That's your contractile layer. And then the most inner layer, endo means within, is composed of simple squamous epithelium. So the epicardium, also referred to as the visceral pericardium, is the outer connective tissue layer that protects the vessel and the sites of nerve attachments. So, all outer connective tissue layers for organs serve really the same purpose. As that organ generally has to expand and contract again, so to speak, is that the outer connective tissue layer reduces friction of that organ with any adjacent or other organs or tissues. It also serves to anchor nerves and blood vessels that are entering and exiting it. So that way they don't vault off, as that, in this case, the heart is expanding and contracting. The myocardium is the middle layer composed of cardiac muscle tissue, and that is your contractile layer. And then the endocardium is composed of simple squamous epithelium. Remember, squamous cells are the more flattened, kind of fried egg appearance type of cells. And so it lays flatter and reduces friction as blood passes through these different chambers. The blood vessels will be lined with a similar tissue. So this picture kind of shows you the orientation of the muscle fibers. When we talk about the sequence of contraction and how blood is kind of moved through these different chambers, each chamber is sort of like its own little balloon. And the upper chamber is called the atria, and the lower chamber is called the ventricles, need to be, contracting in unison. They stretch and inflate like you're blowing up a balloon, and then they need to contract downward or inward and eject and move the blood that has now occupied that chamber and push it to either the next chamber, or in the case of ventricles, you're going to contract and push this blood up into blood vessels. Right, so we have 4 heart chambers. We have upper chambers called atria and lower chambers called ventricles. So we have a right and left atrium, and we have a right and left ventricle. The right side of the heart receives deoxygenated blood from systemic circulation. So all the blood throughout the body eventually has to merge down into 3 major highways: the inferior vena cava, the superior vena cava, and the coronary sinus. And we'll look and see what these where these are located. The heart lab this week, or the cardiac lab that you perform, is going to really help tie this together, because you'll be looking at significant number of models and the anatomy, and then it will give you a better visual picture of what these chambers are and how these major vessels connect to them. So the right atrium receives deoxygenated blood. That's why on models, those chambers generally have a blue tint to it, and the blood vessels are tinted blue in the models, because it's carrying mostly carbon dioxide. So blood returns to the right side of the heart. It does so via 3 sources: the inferior vena cava, the superior vena cava, and the coronary sinus. From there, blood passes into the right ventricle. On its way, it passes through a valve called the tricuspid valve that's found between the right atrium and the right ventricle. So from the right atrium, technically, the blood will then encounter the tricuspid valve and be pumped down into your right ventricle. from the right ventricle. The ventricle contracts and ejects blood through the pulmonary valve to the pulmonary trunk and travels to the lungs where you gas exchange. Then after you gas exchange, the blood travels to the left atrium via the pulmonary veins to the left atrium. From the left atrium, blood passes through the mitral or bicuspid valve to the left ventricle. And from the left ventricle, blood will pass into the aortic valve to the aorta. So these four chambers, the atria, the ventricles, the left and right atria should contract in unison. And when they start to relax, then the ventricles contract left and right in unison. And then you rest, and that is one cycle. The valves within the heart all prevent blood flow, and that's their function. So papillary muscles, or attached to, I should say, the valves, and on the models, this is really evident. You see this kind of stringy white material, and those are called the chordae tendineae. They attach the valves and the flaps of these valves to the papillary muscles, which are muscles that are extensions of the myocardium, that when the myocardium contracts, it pulls down on the chordae tendineae, which then puts tension on the valves, and it prevents the valves from kind of flipping inside out like a cheap umbrella. If the wind gusts, and your umbrella will flip inside out. Well, you don't want that to happen as you're trying to propel blood, let's say, from the ventricles, up and away into their respective vessels. So to prevent the blood from going from a ventricle back into the atria, we have these valves. And by contracting the myocardium and contracting these papillary muscles, which puts tension on the chordae tendineae, it keeps those valves from flipping sort of inside out and becoming what's called incompetent valves, and then therefore that discourages backflow of blood from a ventricle to the atria and forces the blood, when the ventricles contract, to go up and out in a forward direction from the right ventricle to the pulmonary trunk out to the lungs, and from the left ventricle through the aorta and out into systemic circulation. So we have the tricuspid valve, which is found between the right atrium and the right ventricle, the mitral or bicuspid valve between the left atrium and the left ventricle, the pulmonary valve or the pulmonary semilunar valves between the right ventricle and the pulmonary trunk, and the aortic valve or the aortic semilunar valve found between the left ventricle and the aorta. Something that you need to practice and really commit to memory is the path through the heart. And generally we show to the right atrium. And this diagram is very good for indicating that. So on the right side, that is all in blue, represents the gas level of the blood passing through these chambers. So we have the larger chamber, the right atrium. Superior to that is the superior vena cava. Below that is your inferior vena cava. And if you could turn this model around and look at the posterior aspect of the heart, the coronary veins merge to form what's called the coronary sinus. It's just a large vein, and that then transports blood directly into the right atrium. So it shows you with arrows that from those sources, the blood is going to be transported into the right atrium through your tricuspid valve to the right ventricle. From the right ventricle, you're going to pass through the pulmonary semilunar valves, the pulmonary valve to the pulmonary trunk, and the pulmonary trunk splits and bifurcates into a right and left pulmonary artery to transport blood to the right and left lungs for gas exchange. So you can follow either one of those, and it travels out to a lung. It drops off carbon dioxide, picks up oxygen, both sides. They return via two pairs of pulmonary veins to the left atrium. From the left atrium, blood passes through the mitral or bicuspid valve. From there to the left ventricle. And from the left ventricle through the aortic semilunar valves of the aortic valve to the aorta. The first branches off the aorta are your right and left coronary arteries. So you immediately provide as well oxygenated blood as you can to the heart muscle itself. And then it continues the aorta upward and makes kind of a hairpin turn in what's called the arch of the aorta. And there are 3 branches off the arch of the aorta that we will follow in more detail, in the next chapter when we talk about blood vessels. So this shows you that pathway. All right, deoxygenated blood to the right side of the heart. Oxygenated blood returns to the left side of the heart. The 2 atria should contract in unison and then start to relax, and then the ventricles contract and they relax, and that is one cardiac cycle. As a reminder, in AMP1, when we look at arteries and veins, I believe it's in the first lab, where you're identifying arteries and veins, and you define them kind of functionally as arteries transport blood away from the heart and veins transport blood to the heart, which is true. Most arteries will be in the red color because they're very highly oxygenated, or the blood is very highly oxygenated. But there are 2 exceptions to all arteries are red and all veins are blue. And this is one of those examples where you want to keep this in mind. Is that as blood is being pumped away from the right ventricle in the pulmonary trunk, and as the right and left pulmonary arteries, notice that they're still blue. And this is because we have not gas exchanged yet. We need to go to the lungs and drop off the carbon dioxide, pick up oxygen. However, because these vessels are technically transporting blood away from the heart to the lungs, we call them an artery. So this is an example of arteries that are blue. And in return, as you transport blood back to the left side of the heart from the lungs, they're actually going to be red. So these veins are red because they have a very high oxygen content. So not all arteries are red and all veins are blue. There are exceptions, and this is one of them. Okay, so this gives you a list structure to structure, so to speak, of the pathway of blood through the heart. Blood returns from systemic circulation via the vena cava, meaning the superior and inferior vena cava, and the coronary sinus, which is the large vein draining the heart muscle itself. Blood passes into the right atrium, through the tricuspid valve to the right ventricle, through the pulmonary valve to the pulmonary trunk, which then branches off into right and left pulmonary arteries. They travel out to the lungs where they gas exchange. They return via pulmonary veins right and left to the left atrium. From the left atrium, blood passes through the mitral or bicuspid valve to the left ventricle. From the left ventricle through the aortic valve to the aorta, and then off to systemic circulation. Coronary circulation. Coronary circulation, is the pathway of blood to the heart muscles itself and back out again. And so there, all these different arteries and veins technically have names to them, right? But we don't require you to know all the different, little names of these different arteries, just to understand that the first branches off the aorta are a right and left coronary artery. And you can see those on the models. And they transport oxygenated blood directly to the heart muscle itself. They enter as arteries and they branch off into smaller arteries and arterioles and ultimately a capillary bed where we can gas exchange. And then blood will return, deoxygenated blood rich in carbon dioxide will reform into venules and veins to a coronary sinus and take that deoxygenated blood from the heart circulation itself, or the coronary circulation, to the right atrium so it can be transported back to the lungs to drop off the carbon dioxide and pick up more oxygen. So it's supplied by the right and left coronary arteries. They are the first branches off the aorta. Provides intermittent pulsating blood flow to the myocardium during periods of what's called diastole. Diastole means relaxation. Venous blood is collected by cardiac veins, which form a coronary sinus and empties into the right atrium. So why is this important to kind of mention here, that it provides intermittent pulsating blood flow into the myocardium during diastole? Well, the heart muscle continually, hopefully for many, many years, goes through cycles, these cardiac cycles of contracting and passing blood from atria to ventricles and out to the lungs, or out to systemic circulation. And depending on how fast the heart beats and contracts, is going to determine how adequate the actual coronary blood flow providing oxygen and nutrients to the myocardium is occurring. So when the heart muscle itself contracts and that myocardium, the middle layer, contracts, it squeezes down, of course, and the blood vessels that are passing through there gets kind of crushed as well. It's sort of like standing on multiple areas of a garden hose. And temporarily, when you step on it, if you're heavy enough, you block or obscure the passage of water through the lumen of the hose, and no water will pass through it. And that's essentially what's happening in these arteries and veins, that course through the heart muscle itself. Is when the muscle is contracting, it's contracting and squeezing and holding to give each chamber enough time to move and evacuate the blood from that chamber and move it on into, the next area of circulation. And in doing so, it's essentially kind of cutting off its own blood supply. And so when the muscle relaxes, the atria relax and then the ventricles relax, and they'll kind of take a little respite there before you begin another cycle of atria contracted and the ventricles contract, is when you maximize the blood flow passing through these different arteries and veins. So, why is that important? Because when you have ventricular tachycardia, when you had the ventricles contracting over and over and over again, very, very rapidly without significant rest periods in between, essentially you very slowly cut off the blood supply to those working cardiac muscle cells. And they start to essentially become oxygen deficient, and the muscle tissue stops to contract. So that's a problem. You need to have contraction followed by periods of relaxation, to allow oxygenated blood and nutrient-rich blood to regularly pass through the myocardium, perfuse that tissue to provide enough nutrients and oxygen to continue to contract. So here we have a picture of the heart. We can see the right ventricle versus the left ventricle. And from the left ventricle, you can see the big aorta, all right, kind of passes under the pulmonary trunk and pops up and then arches around. And they're showing you, if we could pull back that pulmonary trunk and have a better view of the immediate region distal to the aortic valves on that aorta, you would see the first two branches of the coronary arteries, the right coronary artery and the left coronary artery. And it further branches off to supply, the right and left ventricle and the right and left, the right and left atria and the right and left ventricles. They're not exactly left coronary artery only supplies the left side of the heart, and the right coronary artery only supplies the right side of the heart, like the right atria and the right ventricle. There's a little squishing and overlapping there. But all you have to know is that the first two branches off the aorta are the right and left coronary arteries. There's the oxygenated supply to the myocardium itself, and then we will, the arteries branch off into arterioles and the capillary bed, and then return the deoxygenated blood via venules to veins into the coronary sinus. And so here, we can see how multiple smaller blue venules to veins will ultimately merge to the coronary sinus, which is shaded because it's represented being on the posterior aspect of the heart. In this view of the heart, you're looking, at it from what's called an anterior to posterior view. Like if you were looking at someone in front of you and you were looking at, the position of their heart. So that coronary sinus is actually on the posterior aspect. Cardiac muscle fiber properties. Well, it's abundant in mitochondria because we need to be able to produce a lot of ATP, through cellular aerobic respiration, so that the muscle tissue can contract and relax and contract and relax. Cardiac muscles, are striated fibers. very similar to skeletal muscle, but where these cells, one end of a muscle cell merges with another or kind of interfaces with another, we have intercalated discs. And intercalated disc is sort of like an extra heavy striation. I'll show you a picture in just a minute. If this is a junction point between two cells, and it has two types of adhesions, cellular type of adhesions found there, desmosomes and gap junctions. So preventing cardiac cells from separating from one another or avulsing from one another, we have desmosomes. And in AMP1 in this cell chapter, you probably looked at 3 different types of cellular junctions. You had desmosomes, gap junctions, and tight junctions. And tight junctions are how columnar cells and cuboidal cells adheres to one another, because you have these lengths of kind of flattened regions where they can adhere nice and tight, like you were zipping up a jacket. Desmosomes are kind of like having buttons instead of a zipper, where you have these intermittent points of strong adhesions. And then the gap junctions are like pores that connect the interior and the cytoplasm of one cell to another, allows ions to pass freely, which transmits impulses for depolarization, which begins, is the contractile portion of the impulses, and the myocardium acts as a single unit, not multiple cells. So that as, the way an impulse, the way we stimulated skeletal muscle contraction was because each muscle cell, remember, had a nerve, an artery, and a vein, right? And actually multiple arteries sometimes. But cardiac muscle, there's going to be a particular pathway of nerves and modified cardiac muscle cells that kind of act like neurons, and it's going to stimulate directly certain muscle cells. But the impulse to contract from one muscle cell to another is going to rely on ion movement. Remember, sodium and potassium gates opening and closing? It's going to rely on using these gap junctions for ions to pass from one cell to another, to another, to another, so that the cardiac muscle cell, the tissue essentially will eventually contract and squeeze and contract all at once in one unit and then relax. So here over in the on the right hand side, we can see a picture of what cardiac muscle tissue would look like histologically. You have a lot of those striations, which should look a lot like skeletal muscle, but these extra heavy lines, so to speak, that look smudged, so to speak, those are your intercalated discs. And that is where we have gap junctions and desmosomes. It's abundant. We have nuclei and lots of mitochondria. Over to, in the middle picture, and then to the far right picture is showing you what, the representation of a gap junction would look like. It's sort of like a little pore that connects the interior of one cell to the interior of another. And then the desmosomes are these little extra adhesions, strong adhesions that intermittently kind of adheres one cardiac muscle cell to another. Okay, so heart actions, the heart chambers function in a coordinated fashion. When the atria, the right and left atria, should contract in unison, and during contraction, or the other term for contraction is called systole. After the atria contract and hold, then they can enter a relaxation phase, and that's called atrial diastole. And so diastole means to rest, and systole means to contract. Okay, so when the atria are contracting, the ventricles should be in relaxation or in diastole. And this will make sense because as the atria fill with blood, so let's say we're going to treat the atria like they're independent little balloons filling up with blood. Then we need to squeeze down on those balloons and push that blood down into the ventricles. If the ventricular walls are not relaxed, you're not going to be able to push very much blood into that wall because it's just going to be pushing right back to the atria. So everybody can't contract all at once, or else we're not going to have any movement of blood. So the atria contract and push the blood that is found in those chambers through their tricuspid and mitral valves down into the ventricles. They're relaxed, so now they kind of blow up like a balloon. They fill, with as much blood as being ejected from the atria above them. And then once the atria, the atria finish contracting, they enter into their relaxation phase. And as that happens, the ventricles are now filled with blood, and now it's going to be their turn to contract. And therefore, they contract in unison. They close the tricuspid and mitral valves, that were formerly just open, and those chordae tendineae and the papillary muscles keep those uh, flaps from flipping inside out, those valves from becoming incompetent, so that when the ventricles contract, the blood has only one way to go, and that is from the right ventricle to the pulmonary valve to the pulmonary trunk, and from the left ventricle to the aortic valve to the aorta. So by maintaining closed valves behind them between the atria and the ventricles, when the ventricles contract forcefully, blood only has one way to go, and it keeps heading in this forward direction without what's called regurgitation, backflow. So the atria enter systole, and while the atria are in systole, the ventricles are in diastole. The atria enter into diastole, and the ventricles enter into systole, and then everybody rests momentarily, and another cycle continues. So during a cardiac cycle, the pressure in the heart chambers rise and fall. When the chambers are in relaxation and they're filling with blood, at least at the beginning of the filling portion anyway, the pressure is the lowest. And as blood fills those chambers, the pressure in that chamber starts to rise until finally, as the ventricular walls, the atrial walls contract, whichever chamber you're looking at, as they contract, they squeeze down on the blood, and that increases the pressure within that particular chamber. So at this point, you want the blood to follow the path of least resistance from the atria down into an empty ventricle, and from the ventricles up through to the pulmonary trunk and to the aorta. Important to keep in mind, coronary blood circulation is maximal upon diastole of cardiac muscle. So during its rest periods, cardiac muscle must have a consistent supply of oxygen and nutrients to function. So in atrial systole and ventricular diastole, right, so the atria are contracting, the ventricles are relaxing, blood flows passively from the atria into the ventricles. The AV valves are open, which are referring to the tricuspid and the mitral valves, because they're found between the atria and the ventricles. Right? The mitral and tricuspid valves are open, and those semilunar valves, or the pulmonary and aortic valves, are shut. Okay. Atria contract, push the blood down. Now it's the ventricles' turn to contract. So as the ventricles enter into systole or contraction, the atria are now relaxed or in diastole. When the ventricles contract, the blood is going to start to be pushed against all walls of the ventricles. And what that will do then is push close that tricuspid and mitral valve. Now, the blood has only one way to go. It has to pass from the right ventricle into the pulmonary trunk, and from the aorta and from the left ventricle into the aorta. So in doing so, the AV valves are closed, the tricuspid and mitral valves are closed, and now, upon ventricular contraction, the pulmonary and aortic valves are open. Chordae tendineae prevent the cusps of the tricuspid and mitral valves from bulging too far into the atria by kind of pulling down on those chordae tendineae and putting some tension on them so they don't flip upward and inward, up into the atria. The semilunar valves and the blood flows into the semilunar valves should be open. I really should say the semilunar valves are open, and the blood flows into the pulmonary trunk and the aorta. The atria relax and blood flows, slowly into the atria again. So as what they're just saying is that as the atria relax, the blood that's still coursing through and continues to course through the superior vena cava, inferior vena cava, and the coronary sinus, begin to already start to refill, fill up those atria again, like you're blowing up a balloon. So as the ventricles are contracting, the atria are relaxed, And now the blood from those three sources now start to refill, the right atrium, and the pulmonary valves are transporting blood into the left atrium, and they start to just blow up again like a balloon, getting ready for another round of atrial systole followed by atrial diastole. All right, so when the atria contract, the ventricles are relaxed. The ventricles contract, they push close the tricuspid and mitral valves, and that actually is going to be your first heart sound called the S1 sound. So the ventricles contract, that forces blood to be pushed, against those tricuspid and mitral valves. They close shut. That is your first heart sound. Blood has one way to go. The pulmonary aortic valves are now open, so blood can pass into those vessels. The ventricles contract and eject as much blood as they can into those vessels. And when the ventricles relax, now whatever blood is remaining kind of, part way up into that pulmonary trunk and the aorta fall back downward, and they close the pulmonary valve and the aortic valve. And that is your second heart sound, or your S2 sound. So now it's hopefully starting to tie together a little bit. So our heart sounds. The heartbeat we hear through a stethoscope sounds like the lub dup. Right. The lub is considered the first heart sound. Something popping up on the screen, so sorry about that. Okay. The lub is the first heart sound. That first heart sound is produced when the ventricles enter into systole or contraction, and it is produced by the closure of the tricuspid and mitral valves upon ventricular contraction. The dup, or the second heart sound, is the pulmonary and the aortic valves closing, and that happens when the ventricles relax. That it stops pushing blood weight, up, into the aorta and the pulmonary trunk. And as the pressure behind it starts to cease and gravity kind of starts pulling back down again, then some of that blood falls back down and it closes the pulmonary and aortic valves. And that's your second heart sound. The second heart sound actually has two components, an A2 and a B and a P2. So the 2 represents the second heart sound. The A is for the aortic sound, and the P is for the pulmonary sound. The aortic valve closes earlier than the pulmonary valve, and they are audibly separated from each other, in the second heart sound. This splitting of the S2 is only audible during inhalation. So what they mean is that when you start to practice listening to certain regions of the chest, to listen for the, what you're listening for is, or you're going to regions of the chest where you should be able, with the stethoscope, to hear a particular valve closing the loudest. Right. So there's just certain areas, like to the right intercostal space versus your left second intercostal space, where you can hear one valve closing the loudest versus another. And that's what you're doing with your stethoscope, is to try to listen individually to the aortic valve closing, the pulmonary valve closing, your tricuspid and mitral valves closing. Right. And so you're going to navigate around the chest area to certain regions. If you want to specifically in more detailed manner hear the aortic valve closing separate from the pulmonary valve, because they're rather loud, you have the patient take in a deep breath and hold, and that will help separate those two sounds. Because by holding your breath, it increases the pulmonary pressure. Pumping blood from the right ventricle to the pulmonary trunk and the pulmonary arteries to the lungs, it takes a little bit longer because you've inflated your lungs, and it's a little, the pressure in the lungs is starting, it doesn't exceed the pressure generated from the right ventricle, but you're just meeting resistance to blood flow, pumping it from the right ventricle out to the lungs. So it's going to take a little bit longer for the blood to enter from the right ventricle chamber or ventricular chamber and eject everything it wants to, before that ventricle starts to relax and the blood, kind of drops back down and closes that pulmonary valve. The aortic valve, generally, if you don't have extraordinary systemic, blood pressure issues, is that the aortic valve will close first. So by having a patient take a breath in and hold, you'll get a slight, break between the two sounds that lets you linger over the aortic region in the right second intercostal space and hear that a little bit more in detail, uniquely. And then you can move to the left side to listen to the pulmonary valve. And again, have them split so you can take a deep breath in so you can hear with a little more accuracy the difference between the functioning, of the aortic and the pulmonary valves. The reason why you listen to those is to listen to turbulence of blood flow that might be occurring there. And that's called a murmur. So a murmur is a general term for, is produced as a result of turbulent blood flow that is sufficient to produce an audible noise. So, valves, they can either, they can either open and close normally, or they might not open entirely, which is called the stenotic valve. So instead of a door opening wide open so you can walk right through a doorway, let's say in your house, when you walk in, let's say from the outside and you come into your home, the door generally, will be capable of swinging open, wide open, and you can walk right through the doorway. Well, what if the door only opened 12 inches? Oh, well, then you kind of have to squeeze through, wouldn't you? All right. So some valves can be stenotic and not open entirely, which will produce a certain type of a rumbling type of a flow. And, or one of the other issues could be that the valves are incompetent. So, those papillary muscles attached to the chordae tendineae that attach to the valves, the tricuspid and mitral valves, they're designed to keep those valves from flipping inside out. Well, what if those become weakened or torn and the valves don't, kind of stop at the level of the juncture of the aorta, or the atria and the ventricles, that they flip inside out. And now blood from the ventricles, as the ventricles contract, all right, some of it's going to pass into the pulmonary trunk of the aorta, but a good amount of it is going to squirt, kind of back up into the atria. And that's called regurgitation. So you want to listen to what's happening in each valve to make sure that blood is passing through there appropriately. One produces more of a rumbling sound, one is more of a whistling sound. You'll develop that skill as you progress through your education. This lets you see the location, and it sort of depends on the textbook that you're using. Most of the, as far as I know, currently what they're using in the SPC nursing program, uses these second intercostal spaces to the right and left for the location of the aortic and pulmonary valves to listen to. And then about the fourth to fifth intercostal space to the left of the sternum is where you would listen to the tricuspid valve. And then further, as you travel along that fifth intercostal space and radiate outward toward the axilla or armpit area is where you would listen to the mitral valve. Right? So this picture says they're indicating that you listen to it to the right-hand side of the sternal margin, but and I will try to get this actually replaced with a new picture. They use the left space, just immediately left of the sternum, and then as you travel along that intercostal space and you travel toward the axilla, the lateral aspect, is where you would listen for the mitral valve closing the loudest. Okay, mechanics. Well, we have cardiac output. This is a term that you're going to be very familiar with over time. Cardiac output is the amount of blood pumped by each ventricle in 1 minute. Right. So how much blood is moving and being moved through the heart, for the duration of 1 minute? So CO is cardiac output. We take stroke volume, which is the amount of blood ejected with each heartbeat. And then we multiply that by how many beats per minute. So stroke volume is the amount of blood ejected from the ventricle with each heartbeat. We have what's called the EDV, which is the end diastolic volume. That's the volume of blood in the right or left ventricle at the end of filling in diastole. So essentially, how much blood blows up that balloon, of the ventricles, right? How much, the exact milliliters, quantity of blood upon full blowing up of the balloon. Your end systolic volume is the volume of blood in the ventricle at the end of contraction or systole. So not all the blood is going to be ejected, but most of the blood will be ejected. So you take, the maximum blood that has now filled that ventricle, and then you let the ventricle contract, and then you subtract essentially what is left over, because not all the blood will be ejected. And so the difference between what you started with and what you ended with, right? EDV minus ESV is your stroke volume, right? So that's how much blood is going to be ejected from the ventricles. Multiply that by your heart rate, which is the number of beats per minute, and that tells you what the cardiac output is, how much blood is being moved through the heart in 1 minute. Blood pressure, right? Blood pressure is and we'll talk about this more, in the next chapter when we're looking at blood vessels, in more detail. But blood pressure is the force or pressure exerted by the blood against the walls of the vessel that is passing through. Mm-hmm. So every time your left ventricle contracts and pumps blood into systemic circulation, this is how we're going to pump blood all the way out to all our arteries and pushing it back in the veins back to the right side of the heart. Mm-hmm. Is the greatest when we're closest to the pump, when we're closest to the source of the pump, which is your left ventricle. And as you travel away from the left ventricle, because of friction and gravity and so forth, is that the blood starts to slow down some. And the farther away from the pump you are, the more the pressure starts to diminish. So blood pressure, is a function of cardiac output times peripheral resistance. So blood pressure is the product, I should say, of cardiac output and peripheral resistance. So we know what cardiac output is. We have stroke volume times heart rate. And now we multiply that by peripheral resistance. And peripheral resistance can be due to vasoconstriction. It can be due to the changes in the viscosity of blood, the thickness of blood. When we looked at these oppositions to blood flow, resistance to blood flow in the previous chapter, we talked about the hydration level, the thickness of blood, the length of vessels, the degree of the diameter of a vessel, whether it's vasoconstricted or dilated, will determine how much pressure can be exerted, as well. And so it really falls into those same guidelines. Anything that resists blood flow is going to increase blood pressure. Then we have, knowing now what blood pressure is, we have mean arterial pressure. And this is the average pressure in a patient's arteries during one cardiac cycle. And this is very helpful for people entering the nursing program because they refer to this frequently. Mean arterial pressure, or MAP. You take the systolic blood pressure, and then you multiply the diastolic blood pressure times 2, and you divide that by 3. That's what mean arterial pressure is. You're not going to be asked, I'm not going to ask you, although it would be a good question for you to memorize this equation at this point in time, but I won't be giving you pressures and say, hey, calculate the mean arterial pressure for me. But you should know by definition, that the mean arterial pressure is the average pressure in a patient's arteries during one cardiac cycle. And if you'd like to do a little extra, then I would start to commit this equation to memory. Systolic blood pressure plus 2 times the diastolic blood pressure divided by 3. Blood returning and filling the ventricles depends on how much is being discharged from the ventricles or cardiac output, as well as other factors such as the appropriate maintenance of blood volume and therefore blood pressure. For instance, if you're hemorrhaging and you're losing blood, then this can alter how much blood is circulating back to the heart. The stretching of the muscle fibers stimulate contraction of the fibers. The longer the fibers, the more force that they can exert upon contraction. So what does this mean? It's sort of like different size rubber bands. A small rubber band can only kind of stretch so far. And when you stretch it maximally and let go, it's only going to recoil, so much, so forcefully. But the longer the fiber is and the thicker it is, and the more you stretch it, the harder it recoils, right? If you shoot someone with a little itty bitty rubber band, that maybe one of those little rubber bands you use sometimes on your braces or something, is not gonna produce a whole lot of sting or pain. But if you have a big, rubber band and you shoot it at your brother or sister or someone, now those can really sting. Right? Well, this is the concept I want you to keep in mind when it comes to Frank Starling's law of the heart. It identifies the relationship between a fiber stretching and the force in which it can generate when it contracts. So the more the heart muscle stretches, just in nature, the harder it's going to contract back again and recoil. And that allows the heart to move large quantities of blood, when it's returning to the heart, because it needs to keep moving, the volume that's coming into the right side of the heart, moving it out of the heart and into systemic circulation. So if we're having a higher return of blood and cardiac output is increasing, we need to know that the heart muscle can handle it. So it's very nature, like this Frank Starling's law means that if the ventricles and the atrium, stretch maximally, it's going to be natural for them to contract forcefully back down again to move and mobilize, a larger quantity of blood. If the chambers and you're at rest and you're not, and your cardiac output is low and there isn't a lot of blood actively returning to the heart to be pumped into systemic circulation, then the chambers don't stretch as much, and therefore they honestly don't have to contract as hard or as forcefully either, which then conserves the heart muscle itself over time. So this law ensures that blood is ejected with the same force as it enters the chambers. If it cannot do that, then you start to enter congestive heart failure or heart failure. And that's the inability to move in a forward direction the quantity of blood that's currently returning to the heart. Is that when it contracts, it doesn't contract that forcefully. The amount of blood that's being ejected, starts to diminish, and that residual kind of end diastolic volume is starting to get more and more. Instead of maybe ejecting 95% or 90% of the blood, in a ventricle, upon distension, right? It fills during diastole, you have systole, it contracts. Instead of maybe ejecting, 90 to 95% of the blood, now we're only ejecting 70, 75%. That's an indication of a weakening heart. And that may be due to different reasons, but we're going to get to that. Okay, contraction initiation. When the muscle needs to contract, we have the autonomic nervous system controls heart rate, or basically the parasympathetic division really controls heart rate, and it's consistently slowing it down. We're going to talk about that. But we have both sympathetic and parasympathetic fibers, communicating and attaching to the sinoatrial node, which is located in the right atrium near the superior vena cava. It is here where we can either speed up the heart or try to slow it down, because the impulse to contract is initiated or originates from that sinoatrial node. The tissue here depolarizes the fastest, and so the impulse that is generated from that sinoatrial node rather quickly spreads around the walls of the right atrium and is also carried over to the left atrium, so that the impulse travels down the walls of the left atrium as well, so that they can both contract together simultaneously. So depolarization at that location determines your heart rate or your sinus rhythm. And I will tell you, I'm going to tell you that left on its own, when we were in ANP1, we looked at muscle tissue. We talked about one of the features of cardiac muscle, is that it has intercalated discs, but it also has autorhythmicity. And so what that means is that even if we don't stimulate the heart muscle to contract, either using the sympathetic pathway or, but we're generally slowing it down with the parasympathetic stimulation. We're going to talk about that, at the end of this chapter, or toward the end of this chapter, is that it will be on its own about 90 to 100 beats per minute. And because the impulse is generated from the sinoatrial node at around 100 to 100, 110 beats per minute, are often more contractions than you need, especially if you're at rest, then the parasympathetic division is actually going to send signals down that pathway to inhibit it and slow your heart down, because you don't need to be pumping all that blood. You're just sitting there watching TV or listening to this lecture. But by itself, or left on its own, the sinoatrial node, generates about 90 to 100 beats per minute. And if that is not sufficient, then from the AV node, we can generate impulses from there at about 40 to 60 beats per minute. And then from the Purkinje fibers themselves, around 20 beats per minute. Okay, so we're going to look at the sequence of excitation sequence of events. And we're going to look at one of the images here so you can kind of see that. On some of the models in lab, you'll be able to see portions of this. It's difficult to identify. The myocardium obscures your ability to see the bundle of His, but you can pretty much see everything else. All right, so we begin with the sinoatrial node. This is the primary pacemaker of the heart. And from there, the impulse travels to the atrioventricular node, or the AV node, which is the secondary, or the second pacemaker of the heart, that's found in the interatrial septum just above your tricuspid valve. From there to the AV bundle, or the bundle of His. I still refer to it as a bundle of His. It's the only electrical connection between the atria and the ventricles. So from that AV node, you're going to have this bundle. Kind of looks like like a nerve bundle, that's going to travel to the ventricular septum. And the ventricular septum, the septum is the wall between the muscular wall between the right ventricle and the left ventricle. And it's going to transport and carry this impulse to the ventricular septum. From there, it's going to branch off and travel to the right side of the septum or the left side of the septum, destined from the right side of the septum to provide the impulse to the walls of the right ventricle, and from the left side of the ventricular septum, supply the left ventricular walls. Once you pass what's called the apex of the heart, and which is the inferior pointy part of the heart, you have these branches called Purkinje fibers. And they conduct help conduct the impulse to some of the distal areas of the, I guess you could refer to as the cardiac muscle, runs through the ventricular cells and responsible for ventricular depolarization. Okay, so let's look at the picture, because I think it makes a little more sense by looking at the picture. We have the AV valve, the AV valve, the atrioventricular node, or the AV node, the SA node, and then the AV node here. The SA node is superior to it. AV node is inferior. All right, so we have the SA node, which is considered the pacemaker of the heart, and the AV node, which is the secondary pacemaker of the heart. Okay, so from the SA node, impulse will travel around the walls and what's called internodal tracts, to the AV node, where it recollects, and then it kind of waits momentarily and then sends the impulse down the bundle of His to the ventricular septum. That branches off into a right bundle branch and a left bundle branch. And now follow that, because it's kind of hard to articulate exactly what these Purkinje fibers are, but as they branch, these smaller fibers branch off these right and left bundle branches. And after they pass from what's called the apex of the heart, which is the inferior aspect here, the pointy part of the heart, all those subsequent branches, or the continuations of those bundle branches, are Purkinje fibers. And you see how they travel through in between the different cardiac muscle cells here in the myocardium. In AMP1, we looked at action potentials of skeletal muscle. And I kind of harped on it a lot, so that when we got to cardiac muscle, what is different about cardiac muscle will make a little more sense than what happens in skeletal muscle. And we said that, we looked at some of these myograms and looked at what happens when you have one impulse travel down the motor neuron, and then we release acetylcholine, and it binds to receptors on the sarcolemma, and then the impulse travels around the sarcolemma, down the transverse tubules, so forth and so on. Calcium is released from the sarcoplasmic reticulum, and that it stimulates calcium to bind to troponin and tropomyosin. It unblocks the binding sites on actin for myosin. Myosin, forms that cross bridge formation, and then you have the power stroke, which develops the tension in the skeletal muscle. Hopefully, that brings back fond memories. And that happens, with one stimulus to contract. Well, cardiac muscle is going to get a stimulus to contract. And let me just back up. With skeletal muscle, if you just have that one stimulus to contract and you go through that one cycle, you get one little muscle contraction, a little quiver almost of skeletal muscle, which is not enough to really move anything, to, let's say, lift a weight or to stand up or even hold on to a pencil. You have to have multiple signals traveling down that motor neuron and getting the actin and myosin to ratchet and develop as much tension as possible. So you have multiple signals. But when we want to contract the heart, all the contraction that occurs in the cardiac muscle has to contract and squeeze and hold. The atria have to squeeze and contract and hold momentarily to move all the blood from the atria into the ventricles, and the same for the ventricles. They have to contract and hold and give that blood some time to move from the ventricles up into the pulmonary trunk and to the aorta. It's not just one little contraction. You have to contract and hold. So, but you only have one impulse for this whole cardiac cycle to contract that's being generated at the SA node. So what happens is with depolarization and repolarization and hyperpolarization is a little bit different cardiac muscle. We need to have this plateau, this contract and hold, portion occur when we have one stimulus for contraction. So remember that we always start at a resting membrane potential, all right, or RMP. Generally in cardiac muscle, in skeletal muscle, it's negative 70 millivolts. In cardiac muscle, it can be generally around negative 90 millivolts. Right. So here on the vertical axis, we have our membrane potential. Remember, the potential is the charge distribution across the membrane of the muscle, and it's generally negative. All right. So when we have a stimulus to contract, remember, we have sodium gates that open first. Sodium enters the cell. It causes the interior of the cell to become more positive, and thus the potential becomes more positive. So here at time of 0, this is where we have a stimulus to contract. Right? So you have that upward deflection 1, which is depolarization. Right? So depolarization, the interior of the cell becomes more positive. Sodium gates open, sodium enters the cell, and then boom, sodium gates close because those gates open and close very quickly, those voltage gates. And now the potassium gates finally open. And remember, in skeletal muscle, that would be the downward slope of that line, or the curve of that line is downward, because then we have repolarization. And that's because potassium gate opens, it closes very slowly. So we bleed out all these potassium ions, the interior of the cell becomes negative again. It takes so long for that potassium gate to close that you overshoot your resting membrane potential and hyperpolarize the cell. And then finally, boom, that potassium gate closes, and now you stop becoming, any more negative. So you might stop at around negative 75 or negative 80 millivolts. And then the sodium potassium pump, 3 sodium out, 2 potassium in, restores the resting membrane potential. Okay, now with cardiac muscle, it's very similar, except, so 1, right, first phase is your depolarization phase. Sodium voltage gates open, sodium influx into the cell, same thing, sodium gate closes, we stop at about plus 30, millivolts. Now in skeletal muscle, that potassium gate opens, and that's the only gate that opens, and so we bleed out positively charged ions from the interior to the extracellular space. Well, here we also have a calcium gate. So what happens is we want the voltage across the membrane to kind of plateau and level off. It doesn't exactly level off strict horizontal, but we don't repolarize as quickly as we do in skeletal muscle. So to allow this kind of plateauing phenomena to occur, what that will do is allow the muscle tissue to contract and hold before it starts to relax. And that's what we need. We need to move blood, from the atria to the ventricles, and the ventricles to the atria, to the pulmonary trunk, and to the aorta. No bad. So as the potassium gate opens to allow potassium to leave the interior of the cell, these calcium gates open. Now, calcium is higher concentration outside the cell, just like sodium. So it's going to move from outside the cell and diffuse to the interior of the cell. What does that do to the voltage across the membrane? Pretty much, as you lose one potassium positively charged ion, you're acquiring a calcium positively charged ion, and they're just swapping location. So does the overall voltage across the membrane change? Not really. Now, the potassium is leaving faster than the calcium is entering. So as you can see by this line, it does downward slope, but not as rapidly, as you would, in skeletal muscle where during the repolarization phase. So as potassium gates open, calcium gates close, we have sort of a plateau effect of charge across the membrane, the voltage across the membrane, until finally the calcium gate closes. And now the only gate left open is the potassium gate, and you continue now room to bleed out potassium, and thus explains that rapid downward swing, of that blue line during repolarization. It stops at the bottom when the potassium gate closes, and then the same phenomenon, sodium potassium pump, brings you back to your resting membrane potential. So that calcium plateau, the addition of a calcium gate open and calcium entering the cell as potassium is leaving, stabilizes the voltage, across the membrane. Not exactly never change. It will, continue to repolarize, but not as rapidly as it does in skeletal muscle. And thus it allows a longer period of contraction and being able to move blood. Right? So here they're showing you the same thing. Calcium plateau sustains muscle contraction. It shows you the plateau of being strictly horizontal, but it's not really like that. It does slope down a little bit, and then we see the normal expected repolarization phase of the movement of potassium only during 3, and then restoring resting membrane potential at 4. So sodium in, sodium gate, opens, sodium gate closes, right? The upward deflection where you have 0 there. Then sodium gate closes, potassium gate opens, and the calcium gates open. So as you're bleeding out potassium, you're acquiring calcium, and that stays sort of this plateaued region until the calcium gate closes. And then now we just have potassium movement alone. See, so that's what's unique. If you had to compare and contrast skeletal an action potential, of skeletal muscle contraction versus an action potential of cardiac muscle, now you know the difference between the two. And it also explains the way certain regions on an EKG will appear. Okay, so then we're going to look at electrocardiographs. This monitors the electrical currents through the heart. You have different sensors placed either across the chest and or on hands and feet. And each sensor gives its own individual perspective of the changes of voltage across the membrane of cardiac muscle cells. And each sensor has a different point of view of what's happening in the heart. If you were actually looking at it from your right hand, your left hand, and looking at the heart. And that information is carried on these wires to the central unit that puts all the information from the different senses together and produces a wave on the paper. As the paper rolls, the needle moves and responds to the changes, of electricity essentially through the cardiac muscle tissue. Right? And that's what an electrocardiograph is indicating. there are three major portions of waves. We have the P wave, the QRS complex, and the T wave. So the shape in the P wave of the P wave represents the electrical events functionally of atrial depolarization. Atrial depolarization. How that impulse travels from the SA node, through the atria to the AV node. Then we have the QRS complex. And now two things are functionally occurring there. We have atrial repolarization because the atria contract and then start to relax. And as the atria contract, the ventricles have to start to, and as the atria relax, then the ventricles start to contract. So during the QRS complex, two things are occurring: atrial repolarization and ventricular repolarization. So now that the ventricles can contract. Following ventricular depolarization is our T wave, and that represents ventricular repolarization. So the P wave, we have atrial depolarization alone. The shape of that wave is going to reflect depolarization in the atria only, and contraction there. The QRS complex and the shape of it, we have two things functionally occurring: atrial repolarization and ventricular depolarization. But because the ventricle walls are so much thicker muscularly, there's so much more cardiac muscle thickness and tissue in the ventricles versus the atria, is that the electrical events of this impulse traveling to ventricular muscle tissue way overshadows what's happening in the atria, because the atrial walls, aren't really thick muscle tissue. And so, yes, that it's occurring, but because the thickness of the ventricle walls, it takes longer, and the electrical events there are more profound. The shape of that QRS complex is really representing ventricular depolarization, the contraction of the ventricles. Yes, atrial repolarization is occurring there, but the shape of the QRS complex and then the T wave is ventricular repolarization alone, and then everything rests, and we go through another phase of P, QRS, and T wave. Is that the QRS complex, or lack thereof, is telling you about ventricular functional capability, of contraction and relaxation. All right. So here we're looking at an EKG on the bottom. Here on the top is showing you, okay, here we have a heart. The impulse begins at the sinoatrial node, travels from there to the AV node to the bundle of His, to the right and left bundle branches, to the Purkinje fibers. So we begin by, all the chambers are at rest, and the atria are starting to fill with blood. We're blowing it up like, blood, putting blood in a balloon, and the atria need to contract and move the blood down into the ventricles. So this P wave, upward deflection, and then coming back kind of to a resting membrane potential, but to what's called the isoelectric line, the point where you started essentially, represents atrial depolarization. Sometimes referred to from the beginning of it to the end of it as the PR interval. Right. So the atria are contracting here, and it contracts and holds just that little flat line region before we get to the Q. All right. Now the impulse has to travel down to the ventricles. So we have this QRS, which ends up here back to an isoelectric line. That represents the atria repolarizing, but more importantly, the shape of it indicates ventricular depolarization or ventricular systole contraction. Again, the ventricles contract and kind of hold. That's that ST segment there. That flat line before the ventricles repolarize is, kind of the calcium plateau area where we contract and we hold and we squeeze, and then the ventricles relax and they repolarize, and that is the T wave. And then everybody rests, kind of a flat line there before you enter into another P, QRS, and T. That is one cycle: atria contracting and relaxing, ventricles contracting and relaxing. One cycle. Within here, you can also kind of guess where you would hear the heart sounds, the S1 sound and the S2 sound. We said that the S1 sound is when the tricuspid and mitral valves close, and they close because the ventricles are contracting and blood is being pushed kind of back up toward the atria. And so where we would hear this, we would expect to hear the S1 sound is about the peak of the R there, because that's when you had the ventricles contracting and really compressing the blood, and now it's starting to push up against the tricuspid and mitral valves and forces them to close. So your S1 sound is heard about the peak here of the R wave. And then we said that the S2 sound is a consequence of the ventricles actually relaxing. They've ejected as much blood as they can up into the pulmonary trunk of the aorta, and now they're relaxing, and the blood falls down kind of toward and closes shut the aortic valve and the pulmonary valves. That is your second heart sound. And that's heard about where the apex of that T wave is. Different books will fall. It might be a little just above the peak of that T wave and a little bit to the right, but generally, the T wave, the peak of the T wave is about where you hear the S2 sound, or where you would expect to hear the S2 sound, and the peak of the R wave is when you would be producing the S1 sound. So I like this picture because it helps you visually see what's happening and where the impulse is traveling through what area of the heart and producing what portion of that wave. So it starts with atrial depolarization. You can see the impulse is emanating kind of and spreading from the SA node, across the walls of the right and left atria, and that represents the little green P area there on the EKG next to it. And then you can kind of look at each one and hopefully in your mind kind of put together what's happening in the heart, whether you're depolarizing and repolarizing. Are you holding it calcium plateau and kind of flatlining and kind of picturing, what's happening in the heart and what, what portion of the EKG is representing that functionally. So then we have the AV node, the impulse travels to the AV node. So the atria are contracting, and holding, and that's sort of the flat line. We said that a little, that part of the PR interval, this little flat line region where the atria contracting becomes kind of a flat line. And then the impulse travels to the ventricles. So over on the left, you can see the impulse traveling down the right and left bundle branches. The impulse is now traveling around to the walls of the ventricles. And that portion is represented by the green QRS. The ventricles contract on number 4 here. Ventricular depolarization is complete. Now we contract and hold. Ooh, that little flat green line there. And then the ventricles repolarize. Right? They start to relax and produces that T wave. Ventricular repolarization begins at the apex, causing the T wave. Ventricular repolarization is complete, and that is your one cycle. Cardiac rhythms, sinus rhythm, a normal sinus rhythm, whether it's a normal sinus, bradycardia, or tachycardia, the PQRST portions need to be visible. Right? Heart rates can vary. So your normal sinus rhythm or normal heart rate for most authors is going to be 60 to 100 beats per minute. When you are lower than 60 beats per minute, it's called bradycardia or sinus bradycardia. So when you calculate a heart rate less than 60 beats per minute, it's bradycardia. Sinus tachycardia means you have a heart rate that exceeds 100 beats per minute. Abnormal rhythms produce abnormal waves. If we have abnormality in function or some kind of pathology of the atria, then the P waves will be the ones that are generally affected. We're going to look at 2 different types of abnormalities or dysrhythmias. We have atrial flutter and atrial fibrillation. So it's going to involve the P wave, and that you can generally see a preserved kind of a normal QRS followed by a T. But when we have ventricular issues, ventricular tachycardia or fibrillation, the QRS and or the T wave are going to appear abnormal. As a matter of fact, you probably won't even see anything that resembles a normal QRS wave, not to mention a T wave. You should be able to locate the S1 sound and the S2 sounds. The S1 sound hearts are during the late R wave, just beyond the peak of the R wave, and the S2 sounds are during the T wave, generally about the peak of the T wave for all intents and purposes. There are different ways that you can measure your heart rate. Generally, the size of the strip or the length of a strip that you're going to be, an EKG strip that you're going to be given, is for 6 seconds of time. All right, so it's a 6-second interval. You count the number of full PQRST cardiac cycles that occur in that 6-second strip. If you have 4.5 cycles that you see, then okay, it's 4.5. If you see 5 complete cycles, then it's 5. If you see 9 complete cycles, okay, it's 9. But sometimes you have maybe a portion, like a half of one. So you would take the number of complete cycles or fraction thereof and multiply that by 10, and that will give you the heart rate. Because if you know how many cycles are in 6 seconds, then if we want to know how many occur in 60 seconds, you just multiply the number of cycles you counted by 10, and that tells you how much is in 1 minute, and that is your beats per minute. The SA node controls the heart rate. So, we said that left on its own, you have its own intrinsic heart rate of about 90 to 100 beats per minute that are generated from the SA node in case some other pathway fails. And then from the AV node, you can generally initiate 40 to 60 beats per minute, and from the Purkinje fibers, it's generally about 20 beats per minute. Now, in AMP1, we talked about the autonomic nervous system. We talked about the sympathetic and parasympathetic tone. That we said that blood pressure and the degree of vasoconstriction and dilation, amount of contraction of smooth muscle in the walls of arteries, is under the control of the sympathetic nervous system. But the heart rate is under the control of the parasympathetic division. That's the parasympathetic tone. Why? Because of that intrinsic rate of contraction. We don't need to be letting the heart contract as much as it wants. We need to kind of ride the brake on it and preserve the energy in the tissue for hopefully many, many years to come. So the parasympathetic division is generally riding the brake on the heart to slow it down. So when we stimulate the parasympathetic pathway, we inhibit the heart and we decrease the heart rate. This is the vagus nerve. It releases acetylcholine. And acetylcholine, binds to one of those muscarinic receptors and inhibits the muscle from contracting, and thus spares it from working harder than it needs to. That is our parasympathetic tone or vagal tone. Vagus nerve under cranial nerve 10. However, when we need to speed up the heart, we can do so because that's when the sympathetic nervous system jumps in. So we can override the parasympathetic suppression of heart rate and stimulate the heart rate by stimulating the sympathetic pathway, which increases heart rate. We release norepinephrine that binds to beta-1 receptors to increase heart rate. The cardiac center in the medulla oblongata regulates the autonomic impulses, autonomic nervous system, and impulses to the heart so that we're slowing it down and speeding it up as needed. I love this part. I love when we can connect autonomic nervous system, to that we studied in AMP1 to physiology in AMP2. Remember, parasympathetic slows it down. That's vagus nerve. We speed it up with the sympathetic division. It's called the cardiac accelerating nerve. Acetylcholine versus norepinephrine. This looks a little bit busy, but really all I want you to look at is kind of the top, and then the top, the immediate top. Below the electrocardiogram and where we hear the heart sounds, shows you the waxing and waning, increasing, decreasing pressure that is occurring in the chambers, in the atria and in the ventricles. As the atria contract, the pressure builds up maximally until the blood is moved from the atria to the ventricles, and as the atria contract, pressure decreases. The pressure increases maximally when the ventricles contract. It's ejecting blood, to its respective vessels, and as that volume decreases, the pressure inside the chambers decrease, and when the ventricles contract, it maximally decreases the pressure there. But up on the top, we have the PQRS and the T wave, and that just shows you, below that on that same horizontal, it shows you where you would hear the first heart sound and the second heart sound. Just so you can see kind of where it overlaps on the EKG. That's all. And on the bottom, I will say, if you want to, down here on the bottom, during those same PQRS, so you can go vertically, follow the blue region here, that is about blue through your P wave and almost to your R wave, right? The blue region you follow all the way down, and it'll tell you, which valves are open and which valves are closed. Atrial, AV valves are open and the aortic and pulmonary valves are closed. And then as we enter into, the QRS complex, and we squeeze and hold, then as the ventricles maximally, contract, the AV valves are closed and aortic pulmonary valves are open. And then we finish that one cycle, we enter into another kind of blue region, where the atria are starting to refill, with blood. At that point, the AV valves are open, the tricuspid mitral valves are open, because as the atria fill with blood and they start to stretch, some of that blood is just going to passively, fall down and start to fill the ventricles, slowly. We don't have to wait till the atria contract. So the AV valves or the tricuspid and mitral valves will be open, and the aortic and pulmonary valves will be closed. Okay, so that is the end of the cardiac notes. We will continue the next chapter with blood vessels. We'll talk about, what their functions are, what are their terms. We'll look at the layers, the tissues found there, the function of those tissues, and then name a lot of different blood vessels.